Hello again. It is my pleasure and honor to introduce Dr. Anne Greene. Dr. Greene attended the University of Wisconsin, where she received her medical degree in 1981. She completed her pediatric residency in Syracuse, New York, and then went on to work in Tuba City, Arizona for IHS. She then went back to the East and trained in pediatric and adult emergency medicine in Washington, D.C., and she practiced pediatric and adult emergency medicine and then community pediatrics and homeless health care in Montefiore in New York City. After all this, she was not done with training. She went back and did a pediatric cardiology fellowship at Children's National, and then a pediatric electrophysiology at Stanford University. She was a pediatric cardiology fellowship director at Children's National, and then returned back to UNM in 2015 as the director for the pediatric arrhythmia service. She served as the vice chair for education and is now the vice chair for pediatrics at UNM. So please give a warm welcome to Dr. Greene.
Well, I am trying to share my screen as we speak. There we go. Here we go. Well, thank you for that very warm introduction. I am sort of an addict to training, which is kind of where that comes down to. And I'm really happy to be here today to talk about EKGs in the newborn period. I thought a lot about what to discuss, and so mostly I'm going to talk about patterns that you might see on EKGs in the first days and up to about a month of life, so that there's sort of red flags that you want to be aware of. So we all kind of know that EKGs change as babies grow and develop. In the first month of life, the heart rate is certainly a lot higher than we see in older kids, and we sort of know that intuitively. We know when a baby's heart rate is too fast. Intervals will increase as your heart rate decreases over time, but the QTC will stay the same because it's corrected for heart rate. The normal axis shifts from a rightward to a leftward axis from newborn to childhood. And we'll talk about that a little bit more. And normal voltages change too. So you kind of need a cheat sheet. And there are lots of good ones. Harriet Lane has good intervals. And if there's anybody who wants a cheat sheet, I can certainly send that out. Sometimes people actually, in the heat of the moment, need a 2-second refresher on how to measure. And the PR interval is pretty easy. It's really a PQ interval. QRS goes from the Q wave to the end of the S wave. But I think sometimes people have a hard time with the QT. And so if you happen to have this extra bump that's a U wave, which is very common in newborns after stress, and it relates to electrolytes and things like that, you need to draw a baseline straight across and then intersect it with where the T wave would hit. A little bit of trigonometry, and that's where you measure the QT so that you don't create long QT syndrome where there isn't. And I will show you some long QT in a second. So in the first month of life, take your eyes down to this third diagram for axis. This is where all newborn babies should be. And it really goes along with all the other things we know about newborn cardiac physiology. The RV is predominant, there's some RVH, the pulmonary vascular resistance is quite high, and that is why you have RV predominance, because obviously the lungs haven't been open. So you'll have what would be a right axis deviation in an older child, but it's completely normal in a newborn. And there's only 2 leads you need to know to look at for the quadrant that your QRS axis is in. So lead 1 is straight across from your arms. It should be towards the right. And in our way of looking at EKGs, that means that lead 1 is going to be negative or mostly negative. And AVF, which is pointing down towards your feet, should always be positive. You never want to see a negative complex in AVF because then you have a superior axis, which is always abnormal. So when you get your EKGs back, the numbers should be over here between 180 and 90 in this quadrant. That is the newborn quadrant. If you got a baby with a left axis deviation, you should start worrying about congenital heart disease. Either that or the leads were on wrong, but if they're on properly, that is not normal in a newborn. Again, this is how to measure amplitudes and intervals, and you need a cheat sheet to know what's normal for amplitude. I used V5 and V6 to look for LVH, and 20 millimeters in V6 and 30 in V5 are good ballparks, although it varies a little bit with age. And for RVH, I will show you in a minute. So that relates to this business of the T wave axis changing with age. So when babies are first born, their T wave should be upright in V1. That's our right-sided lead. Some texts say 5 days, 5 years, but it's 7 and 7 is, I think, the easiest way to remember. And it should be upright for about a week. If you have a 3-week-old in your nursery and the T waves are still upright in V1, then I would be worried about right ventricular hypertrophy. You wouldn't be surprised to see that in a baby with pulmonary hypertension, or a baby who's been on ECMO, or a baby who's got right ventricular hypertrophy because of pulmonic stenosis. Any of those reasons that the RV is still staying very predominant. Once it flips down in V1, then there's what I call progression across the precordium, which I'll show you in a second. And it needs to follow this pattern, which I'll show you in a sec. This is my checklist for reading in EKGs that I've sort of used for years. It kind of follows that mantra that we learned with Dubin in school. And it's kind of like a song you sing to yourself, you know, rate, rhythm, axis, intervals, morphology, with the caveat that if there's something wrong with rhythm, just like if you were resuscitating a baby and you found something very abnormal, you have to then go down to arrhythmia recognition. And that's a whole nother algorithm. So this is a normal EKG for a 1-day-old. The QRS axis is 120, so it's down in that right quadrant. And the T waves are upright in V1, and that's completely normal. And then the next one is a 2-week-old. And now we want to see that the T waves are down in V1. So up when you're born, down by a week of age. The QRS axis has already moved over a little bit towards the left side. That's okay, because you can see there's a huge normal range. The amplitudes are fine in these leads, but what I really wanted to focus on was it was upright at birth and now it's down. And this business of across the precordium is that it's down and then it kind of starts to change a little bit as we move across the precordium. And by the time it turns upright, it needs to stay upright, or now we have issues with the left ventricle. So just to give us our cartoon version of the conducting system, we have a sinus node that kind of lays along the boundary between the venous structure and the atrial structure of the right atrium. And electrical signals go across the whole left atrium and right atrium, and they kind of funnel back towards the AV node. And this is a gatekeeper structure that keeps us from giving too many crazy beats down to the pump, to the ventricles. Then there's a skinny little thing called the bundle of His. And then there are bundles that go down either side of the septum. And that is how we activate the ventricles for every complex. So this is coming from your sinus node. This space here, the PR interval, is the time it takes from SA node to AV node. The QRS is this conduction down the bundles of His. And then the T wave is more of a biologic, biochemical process of repolarization way down at the cellular level. So this is a newborn with an irregular heartbeat. Really common. Some babies have tons of these, but this is I'm sorry, this is very touchy. This is a early beat, much quicker than we're seeing here. And remember, this heart rate is about 300, 150, 100, so it's about 120, 130. And you can see a P wave and then an early beat. So this is a premature atrial contraction. And even with a PAC, you can have a little bit of a gap between the next beat. And here I actually see another PAC that's probably blocked. Lots of newborns have PACs, lots of fetuses have PACs, Lots of PACs either conduct aberrantly with a wider QRS, and this is a little bit wider, or they can block. You can have atrial bigeminy where every other beat is blocked, so your heart rate can jump between 70 and 140. And all of those in a structurally normal heart are benign. It can go along with substance abuse or substance exposure with infants, lines in the right atrium, lots of different reasons to have PACs. This is another type of atrial variant that you may see where you have a couple of different kinds of P waves. So here's kind of a big one, here's a small one, and then these are biphasic or inverted. That is called a wandering atrial pacemaker. It's not abnormal. It is just a variation of alternate pacemakers taking over, but as long as the rate's not fast, we don't worry about that. If you saw this and you were having runs of tachycardia up to 280 with a different P wave, you would look back in this and say, well, I guess there were different foci, but we don't necessarily pursue this if there's no symptoms. And here's another pattern that you might see on a newborn EKG. Picture that maybe there's a central line that's tickling the tricuspid valve, for example, and now you're having premature beats, but these are wide. So these are going to fit into our category of a premature ventricular contraction. One of the ways that you can tell the difference between that and a PAC with aberrancy is that you won't see a P wave in front of it anywhere. And sometimes you'll see a P wave after, which just tells you that the conduction is going back up the AV node, which can happen in a newborn. And this would be a little bit more ectopy with couplets and triplets of PVCs. Once we see something like this, we start to worry that there's actually something going on in the myocardium. Maybe this child has myocarditis. Maybe there's a channelopathy, needs further exploration. So some EKGs can make us suspicious of structural heart disease. Here is an EKG. So we talked about axis before. So just take a look at AVF and at lead 1. So AVF should always be positive in everybody because the forces that go down the His bundle and the left and right ventricles are all pointing towards our feet. So that means that the forces coming towards AVF or foot should be positive, okay? This patient, it is negative, which means that for some reason, the forces in this EKG are superior. They're pointing up, which is never normal. And if you look at lead 2, that is also an inferior lead, that is also negative, and so is lead 3. So we have a sense that there's something wrong with the vector of this child's EKG, and so we know it's a superior axis. And then we look at lead 1, which also should be pointing towards the left. It should mimic V6. And so therefore, it should be positive once you get out of that absolutely brand new newborn period. And we see here that it's a little bit more negative than positive. So this is going to put our EKG in a very abnormal quadrant. It's going to be straight up and to the right. And in order to not confuse people, we call that northwest axis. So if you look back in the beginning of the presentation, because I think you have it available to look back and forth at it, you'll see it's going to be in that right upper quadrant. Think of it pointing towards your right shoulder. This is a classic EKG for a baby with an AV canal. So if you happen to have a baby with trisomy 21 and you do an EKG and you see this, you're going to think to yourself, I think this baby has an AV canal. We really need to get this child seen. They actually probably aren't going to get into trouble immediately, but they need to get fit into cardiology as soon as possible because they may show symptoms by about 2 weeks of age. So this is a picture of an AV canal. And as you probably remember, the endocardial cushions don't come together. They're supposed to come from all 4 directions and meet. And so there's no real estate in the middle of the heart. You can have a huge VSD component, a huge ASD component, or small or almost nothing of either of those, and it will definitely change the physiology. But the axis of the EKG is going to be superior. And the reason for that is that we're missing real estate at the bottom of that right atrium. Remember where the AV node is supposed to be. And it has to find a new home because it's not able to migrate there and form there embryologically. So that's the normal AV node position. And what happens with the AV canal patients is the AV node position is way more posterior, maybe a bit inferior. That can change, there's variations on that. But so we have the beginning of the QRS complex not starting here and going down. It's actually going to have to take a little loop to get over to the septum. So the reason for the superior axis is anatomic. And instead of having your QRS go this way, it's going to go up and then down, and that is why you get a superior axis. Okay. Take a minute to look at this EKG and see if it makes sense to you that this is somebody who has a WPW type pattern. So the QRS is very wide, as you can see, and there's a few reasons for why a QRS would be wide. It might be slow conduction, you might have a conduction defect, or your QRS may be starting too early. And that is what this shows because the PR interval is very short. So we have a short PR interval. We're not taking the time that we usually do to get from that SA node to the AV node. And the QRS is starting much earlier. So what that means is that hiding within this QRS is a normal one that's going down the AV node. But this part here, called the delta wave, is starting much too early. It's pre-exciting a part of the ventricle. Now, you can have this with a totally structurally normal heart, but if you happen to have WPW on a newborn EKG, there's one particular diagnosis you would want to rule out. The reason that you have the pre-excitation again is that you're having this part of the ventricle, for example, getting excited at the same time as this. It happens quicker because there's no safeguards on this pathway. And so you get a combination signal of the normal QRS and the early one on top of each other. And this will be the delta wave. Now, this is the classic structural heart disease that is causing WPW. Again, you can have it with a normal heart. This particular lesion is called Epstein's. It is gigantic heart because the tricuspid valve is plastered way down towards the RV apex. And this huge part of the RV becomes what we call atrialized. And so this gigantic atrium will just about fill the right side of the heart. It just dilates up massively. So even though embryologically it's not exactly how it happens, I find it's easy to remember that instead of having your tricuspid valve up here where it belongs, it's way down here, and it can sort of, in a way, pull embryologically other strands of tissue, and those will be accessory pathways. So it's a little more complicated than that, but I really find that that helps me remember that when I teach it to folks, that one of the things you can have in WPW is Epstein's, and it can be a mild Epstein's. This is very severe, but you might only have it a little further down like this, in which case you don't get such a giant atrium, but you can have pre-excitation. These patients can have 2 or 3, I've seen up to 5 accessory pathways. But when we do an echo on somebody with WPW, we're looking for that. We're looking for subtle Epstein's. Chest X-ray, of course, would be very helpful. So if you had a newborn with this and you got a chest X-ray and saw that, you would have your diagnosis pretty much, even though you still need to get your echo, of course. So here's a kiddo who was delivered emergently at a heart rate of 240. It got up to 340 at one point. And besides having a fairly large heart, but not as big as the last one, you can see there's a ton of edema, this whole body edema, and the lungs are quite wet too. And there's pleural effusion over here as well. And the reason for that is this baby had been in SVT at a rate of about that for, we think, maybe 2 weeks at the end of pregnancy. And so one of the things that you're faced with the newborns is figuring out Is it sinus tachycardia or is it SVT? You sure don't want to give medications or cardioversion or even just ice on the face to somebody who has sinus tachycardia because they're septic, they have NEC, they have respiratory distress. So you want to be able to figure out if it looks like a sinus tach versus an SVT. And of course, the PALS algorithms that people use to differentiate this for older children at a heart rate of 220, that's too slow, I think, to help us sometimes, especially with more premature babies, because obviously their sinus tachycardia rates can go much higher than that. Remember, if you're in a tachycardia, you're not always going to be able to tell if it's WPW. But usually SVT has quite a fixed rate and it'll start and stop suddenly. And you really look for P waves and you won't see them just ahead of the QRSs like they're supposed to be. So here's a kid. This is a pretty typical SVT type EKG for a newborn. And as you can see, this heart rate is 300, so very fast. There's not really any question that this is a sinus tach because it's just too fast. And sometimes you can see little tiny blips kind of right after the QRS, not in all the leads. And sometimes I can tell you, aha, I see where that conduction is going back up. But basically, this is narrow complex, it's really fast, and we don't see P waves in front of every QRS, so that's going to be SVT. And 99% of newborns who have SVT are going to have an accessory pathway, whether they have WPW or not. WPW is helpful to prove it to us, but they are going to have an accessory pathway as the mechanism of their tachycardia statistically. Here's what it looks like when SVT starts. So you can see we had a medium heart rate with a P wave in front of it. Then you get a little bit of aberrancy, which is not uncommon. And then you go into this fast rate of about 300. I always ask the trainees how they're going to explain this to somebody on the phone. Again, narrow complex, I don't see the P waves. And especially if you saw that transition, that's really helpful. Here we are still in the SVT. We do something here, either ice, adenosine. When you do those things, don't be surprised by all kinds of funny stuff happening. But as we come out of the tachycardia, now we see there's pre-excitation. Very short PR interval and pre-excitation. Again, I'm already assuming this is an accessory pathway, but it's helpful to see that it's WPW because especially in that situation, I'm really going to want to make sure it's not Epstein's as well. So after conversion with adenosine, you'll see again, the PR interval is really short and the QRS starts early and there's a wide complex. So this is WPW. I did want to point out that when you have pre-excitation, you may see some very strange T waves out in the lateral leads. That doesn't mean that there's ischemia necessarily. It's just that if you have abnormal repolarization, and just look how short this PR interval is here, you can have abnormal repolarization also. And the reason that we get those types of SVT is in sinus rhythm, we're going down both at the same time. Something happens to block that conduction in the accessory pathway. So then it just goes down the AV node and the normal conducting system and can come back up the accessory pathway and starts to go into a circle. And sometimes we see a hint of that by seeing a P wave that gets created with that, but not always. So here's a newborn who had fetal tachycardia and intermittently had heart rates of 300, but also had heart rate sometimes to 150. So interesting is going sort of double the rate and then half the rate. So just take a minute to look at this EKG. The rhythm strip, which is lead 2, is very helpful. You kind of train your eyes to what's happening here along the baseline. So these are very strange looking waves. Those are not normal looking P waves and really hard to tell where the T waves are, by the way. But these big kind of waves are called flutter waves. So this is a baby who's in atrial flutter, but luckily that AV node is protecting us towards a super fast rate because this rate is at least 300. Sometimes flutter can go 400. But the AV node is doing its job and not allowing every beat to get through. This is what can happen when you give adenosine. Maybe you're not sure, maybe there's less obvious 2-to-1 or 3-to-1 block. You will then block the AV node even more, and you may see the flutter waves come out. So in this case, it's 1, 2, 3, 4, almost 5 beats in between. Careful with adenosine in a brand newborn, because if they're acidotic, you might get a prolonged effect as opposed to the 10 seconds. So if the baby's stable enough, you may want to fix acid-base balance, things like that, before giving it. Of course, the other way to get rid of atrial flutter, if you need to, and the baby isn't stable, is of course cardioversion. And usually once you get babies out of atrial flutter, it stays away. Sometimes come back once, but this is not the kind of rhythm that we normally have to treat for a year like we do with SVT. And the mechanism for atrial flutter is not the same as that big circle we talked about with reentrant type usual SVT. It's a reentrant rhythm, but it's just up in the atrium, kind of going around in a circle like this, up the septum, down around the edge of the right atrium, actually kind of goes through the tricuspid valve, isthmus, and then back up. And so it's got its own life, which is why when you give adenosine and block the AV node, you still see the flutter waves, even if it's not conducting. Okay, I know this would be a very bad day if actually all these kids were in the NICU at the same time. So deep breath. Initial vita signs during delivery and perfusion can make us suspicious of a channelopathy. So now we're kind of switching to the more of the biochemical type things, but with some macro added in. So here's a newborn who's brought to the Well Baby Nursery after an uncomplicated delivery. And the nurse calls you because the baby's heart rate is only 53. So that, you know, triggers in all of us, do we need CPR? But the baby's pink, so that's not happening. And I should say she or he is doing CPR. And so the following EKG is obtained. So there's a lot to this EKG, but I just want to start with the basics first. So first off, the rate is very slow. If we decide that these things that are larger seem to be the ventricular complexes, okay? And it's around 50-ish, like the vital signs were. And this is what I do. I do it by algebra. I assign a value. Okay, that's my QRS. I'm not happy with that QRS. It's a little too wide. I have to think about that. I put that on my invisible clipboard to come back to it later, but I've decided those are my V's. Okay, now, which ones are my P waves? And this is not always so easy either. And because the P waves can jump on the T waves and things like that, but this seems kind of too close. We'll come back to that complex. This kind of seems too close to a QRS. That could be a T wave. It seems about the right amount of distance, but I'm getting the feeling that these smaller waves are the P waves. So that's the next thing I do is I label them literally. These are my P waves. Okay, now I have to go back and figure out what are my T waves. And what's left over are these bigger waves here. That's sort of superimposed, but here's a good one. So that distance is gigantic for a QT interval. So that's also on my invisible clipboard. So the QTC is very prolonged. Okay. And then my question is, do these P waves have anything to do with these QRSs? Are they associated at all? Is it 2-to-1? Is it 3-to-1? Or is it complete heart block? And the way I look at that is once I've decided which are the P waves and I can march them out, they're probably hiding here, one here, one here. And the P to P interval is very regular. And then the QRS to QRS is very regular. And the PR intervals are changing. That means that they're definitely going to their own drummer. There's a regular ventricular rate, there's a regular atrial rate. And because of that, we see that the PR interval is short and long and short and long, which means that the P waves are not driving this at all. Okay, so that's about 4 things on this EKG. Now this, getting back to this is a wide complex. but this is a nice narrow complex. So this would be what we'd call a junctional rhythm, but this is lower down in the ventricle. So taken all together, the things that are wrong with this EKG are very bradycardic, and the ventricular rhythm is a wider complex, so down below the AV node. There's complete heart block, and there's a very prolonged QT. So this baby has congenital long QT syndrome, which can present with complete heart block. So again, if you got this EKG on a baby with a slow heart rate and you saw this pattern, you'd want to look at, first of all, what's my ventricular rate? Secondly, is it a nice narrow junctional? No, it's a little bit wider, so that's not good. And then does it look like my P waves are conducting at all? And that you might need some help with. Usually it takes 2 or 3 people to put their heads together and think about this, but you'd be worried about complete heart block. And then it would kind of come after you had lined up what all the beats were, that the QTC is long too. So this baby is going to need a beta blocker because of the long QT. There's no way we can give this baby beta blockers until we have a pacemaker in. And here is the labeling of the waves for you to look at. So just to think about long QT for a minute, first off, for most babies, EKGs in the first day of life are not helpful in terms of deciding if they have long QT or not, because the stresses of delivery and the high catecholamine and all the vagal things that happen with delivery can really prolong the QT, can flatten the T waves. So the data is you can't really trust it till 3 days of life, which is why we a lot of times have to repeat the EKG a couple of times. Now, if we know mom has long QT syndrome, we get an EKG where the QTC is like 600, I'm going to believe that. But if it's a baby with no risk factors, except for having had a difficult delivery, I'm not going to call him long QT right off the bat. I'm going to watch him and I'm going to get another EKG, but I really wait till day 3, if I can, to make that diagnosis. There's a whole bunch of long QT types, up to about 17 now, and we think 1 in 2,500 people carry a gene for long QT syndrome. So clearly penetrance and phenotypes are not all the same. But for the most part, the highest percentage are going to be type 1, the first one that was discovered. It's a potassium channel defect, and the EKGs show really big, broad-based T waves. And these are the kids later on in life that we worry a lot about cold water diving as a stimulus to the diving reflex, and therefore sets them up to have pause-dependent torsades. Type 2 is also a potassium channel defect with a decreased current. Those T waves are actually flat, notched, really hard to measure. And these are more loud noise triggers in sleep, which of course we have all around babies when they're in the hospital. And then type 3 is a totally different animal. It's a sodium channel defect. There's actually too much sodium current. They will have a very flat ST segment, and the T wave will be really far out, sort of like the baby that we just looked at, where the T wave is so far from the QRS. And those kids actually don't need triggers. It's when they get bradycardic that they have events. Here's an example of an EKG of a patient with long QT syndrome. You can see how bizarre the T waves are with this big notched and this huge portion here. And here's another patient with long QT syndrome as well. Rule of thumb, and this doesn't actually play out here, if you have a QT that's longer than half of the R to R interval, or more than 50% of the R to R interval, that's going to come out to a QTC of about 500. But you can certainly have long QT syndrome without that pattern. So this is another channelopathy type patient, but we'll have a very different looking EKG. So this baby had a seizure with fever. There's a family history of sudden death. And this baby has a very classic pattern for something that we call Brugada syndrome. And what you see with that, it's interesting because it's the exact same gene locus as type 3 long QT syndrome, SCN5A it's called. But in this situation, there's too little sodium current, whereas the long QT patients have too much. And it produces a very specific, fascinating EKG pattern in V123. and you'll have an RSR prime with ST segment elevation, which is what this is. This isn't a wide QRS, it's ST segment elevation. There's a little bit here. This is harder to tell. You have to have it in at least one lead. And it goes with family history of sudden death, usually in young men in their 20s. And all of these channelopathies are autosomal dominant in terms of how they are inherited. There is one type of long QT, one where you have two bad copies of the gene, and that's associated with deafness. It used to be called Javral-Lang-Nielsen syndrome, and they have an incredibly long QT as well. So again, if there's long QT syndrome, I make sure they get hearing tests, but luckily all newborns get that. Other way around, if kids actually have hearing loss, these days the pediatricians know that they need to get EKGs. The ENTs always send patients to me before they're doing cochlear implants and things like that. But this is a classic Brugada pattern. And interestingly, if you Google Brugada and you go to the Wikipedia site, it shows you a perfect example of that in case you need a fast reference if you're not sure. Okie doke. So other structural lesions with ECG findings in the newborn period. This is a patient who has what we call Koch-Wachtel criteria for biventricular hypertrophy. The R wave is way up here and the S wave is way down here. It's the only time we really use the V3 and V4 for looking for hypertrophy, but if this is over 55, even if we don't see other evidence of hypertrophy, we call that biventricular hypertrophy. And that could happen in a patient who has a big VSD with biventricular dilatation. You may not see that right away in the first week of life, but as they start to go into failure, as they get towards a month and the PVR goes down, you might see that pattern on a 1-month-old. This is a patient who has right ventricular hypertrophy. And again, they don't have that nice negative T wave that we want to see in a 7-month-old or even in a 1-month-old. And also there's a clue that there's a really loud systolic murmur at the left upper sternal border. So that would be consistent with pulmonic stenosis. That makes sense. You would see right ventricular hypertrophy. You would assume that there's something obstructive, either here for pulmonic stenosis or way out here for increased pulmonary vascular resistance, pulmonary hypertension. May not be able to tell the difference between that, of course, on an EKG, but you would be wondering that. And again, it's all about this T wave business. This is flat and even upright in a couple of those complexes. So that's RVH till proven otherwise. This is an EKG of another kiddo who is a week old and has not flipped their T waves down like you'd expect and has some pretty big voltages. This is another lesion that you could get a RVH. So this is tetralogy of flow. You can have severe, you can have mild, you can have no flow through the pulmonary valve with tetralogy, as you know. They're going to have a big VSD. And early on in life, most of the flow is going to be left to right. And this is going to be the obstruction. And because of that obstruction, this gets thicker right underneath the valve, and the whole RV gets thicker as well. And so you'll have a pattern of RVH on the EKG. So this is a gnarly looking EKG. And the things that I want to point out here are huge voltages over in the left-sided leads. Can't even see, they go up into the other voltages, and there's kind of a peaked looking T wave here, but also these leads here show some very bizarre looking inverted T waves. It's not out of the progression, you know, it's negative, negative, biphasic, and then up, but there's something funny going on with T waves in here. And this is actually a patient who has hypertrophic cardiomyopathy, mostly left-sided. Other thing I'll point out is there's kind of a short PR interval here. That can happen with some patients with LVH as well. They can have extra connections from the atrium to the ventricle. But what you would see on echo, this is the parasternal long axis, and this is the short axis view. This is the normal one with plenty of room in the LV going out the aortic valve. This is the incredibly thick one. That's how thick the septum is. And the mitral valve may actually almost touch the septum in systole. But most impressive, I think, here is that instead of having all this room in the heart, that's all you get. So these kids are very volume sensitive and may show you a bunch of other things, that they get hypotensive, if they get dehydrated much quicker. They may have an outflow tract murmur. There should be some other things that will clue you in, but the EKG may show LVH. So interestingly about coarctation, in the fetus, the coarct is often right at the point of where the PDA enters the aorta. So the RV actually sees the obstruction even more so in a sense than the LV, because the LV is pumping against obstruction, but the RV not only is dealing with the high PVR, but also the obstruction at the coarctation, and they are going to have persistence of that RVH type pattern past a week or so of age. Eventually, if a child's older and they don't have to have emergent surgery and they come in at age 2 or 3, their EKGs will definitely show LVH, but in the newborn period, it will be RVH. And so here's a baby with RVH and some right axis deviation. But again, remember, this is a newborn, so it's very hard to tell if there's RVH other than the fact that there's big voltages. So coronary issues can present in the newborn period. I want to show you a couple of EKGs that are kind of classic for that. Just looking at my time. Okay. So everyone's heard of Al-Kappa, anomalous left coronary artery from the pulmonary artery. What happens here is that as the great vessels, which start out as one and then septate and then have to transition into turning and spinning, the coronaries have to migrate from what was their spot on the single truncus over to the aorta. But sometimes it doesn't quite make it, and it stays attached to the PA. So this should be here, but it's over here. So again, everything depends on PVR changes over the first month of life. And in the beginning, the pulmonary artery may not have the most beautiful blood, but it's got a high pressure because of that PVR. So it'll push enough blood down the coronaries to support circulation, even if there's microischemia that's happening. But at a month of age, when the pulmonary artery pressure drops a lot, all of a sudden you now have a sink. So all this blood is dumping back into the pulmonary artery and you get acutely ischemic. And those babies will present with irritability. They look a lot like Santafer syndrome with reflux because it's a visceral pain. And of course they're writhing, they don't know what to do with it. And you know, the differential is like, is it a corneal abrasion? Is there a hair tourniquet? But if this is really what's happening, not only will they be irritable, but they'll be poorly perfused. And there's a classic finding on the EKG that you don't want to miss. So it's okay to have a little bitty Q wave in one in AVL, like down to about there where I'm pointing. But a big Q wave in one in AVL is classic EKG finding for this L-kappa. It means you've already had some infarct, but that's not surprising as the blood is not flowing as well to those. And there isn't enough time for a newborn to achieve collaterals, for example. So big Q waves in one in AVL. And sometimes the EKGs come with arrows, but not always. But just those are the two leads you want to look at. If you have a really irritable baby who's poorly perfused and you're doing everything else, if you get an EKG like this, you need to call cardiology. These kids need surgery. There's another type of anomalous coronary that I just wanted to point out the difference. So the newborn one we're talking about coming from over here. If it's just the phrase anomalous left coronary, and this usually presents later in life, that means that the left actually is coming from way over by the right coronary. And it tunnels through the back of the aorta, and as kids get older and exercise, it starts to get compressed and they get ischemia. These kids usually show up later, but I want to explain just to make sure you know the anomalous left coronary from pulmonary artery is the newborn one, and just a normal anomalous left coronary, so to speak, usually presents later in life and would give this kind of scary EKG. This is an older kid who collapsed playing soccer. And this is more classic of the adult findings in an MI with big ST segment elevations, reciprocal changes. Okay. So to summarize, newborn EKGs show RV dominance with a gradual shift towards the leftward axis over time. Intervals decrease as you'd expect. There are EKG patterns that can suggest specific structural disease. Reentrant SVT is a common type of tachyarrhythmia in the newborn. WPW is a common cause, but it's only about half maybe of the kids with SVT, and we assume all of them have a accessory pathway. These are some references you can use for further perusal, and I would be happy to take any questions.
Everybody's been pretty quiet this afternoon, but I do have a couple of questions, Dr. Greene. The first one is, if we're doing EKGs for suspected issues, and we get one the first day, how should we time them out? Like you said that you should follow them over a couple of days to see if they normalize. So every 12 hours, every 24?
Yeah, that's a great question. Well, it kind of depends on what you're doing it for, right? You're talking about if it's for QT in particular?
Yes.
Yeah. I think if you can do it, I would usually do them once a day for 3 days. They're not going to change that much in 12 hours. The one thing you would be, of course, it's different if you have, heart block or you're seeing ventricular arrhythmias. I attended a delivery quite a few years ago. We knew that this baby probably had long QT in utero because she had heart block, and then on her last fetal echo, she had VT that came and went. But I said, okay, there's only one reason that a fetus is going to have heart block and VT. So we were in the delivery room with that baby, and we had the neonatologist put in lines right away. And I basically gave the baby lidocaine at about, 4 minutes of life because she was in torsades at birth. So obviously that's a whole ridiculously other end of the spectrum kind of a situation where you're intervening and doing all that. But if a baby's fine, but I would submit that it's good to keep them till day 3 of life to get an EKG. I know we send a lot of kids home at day 2, and then I have to have them come back in a week, which isn't really ideal. And there I just do a risk assessment, like how likely is it that this baby has long QT and it's not just related to stress at delivery and, all the family history and, things like that. Does that make sense?
Yes, it does. Thank you. The other question I had, this is it's kind of fuzzy a little bit. I teach a class called Stable. I'm sure a lot of people have taken it. And in that class, they talk about SVT at a heart rate of 220, but you mentioned that you feel like that might be too low to say, oh, that's what that is. So
I know.
Is there a clearer way to to look at that?
Well, that's why I was talking a lot about if you see P waves in front of every QRS and the heart rate is 225 in a baby that has clinical reasons to be hypovolemic or dehydrated or is febrile or has, compartment syndrome or whatever, then I wouldn't jump to the conclusion that it's SVT just because it's a 225 heart rate. On the other hand, there are kids, I didn't put this in because I was trying to make things really clear, I hope, but there are some forms of SVT, even in newborns, that could be a little slower, but they won't have that normal P wave in front of the QRS.
Okay.
But I think it really hinges on getting a good EKG, because sometimes you can't see the P wave great in your telemetry. You don't happen to have that lead on, or a lot of interference, lots of stuff going on at the bedside, obviously. But that's really probably what you want to spend some time seeing if you can see if there's a P wave in front of the QRS. Now, once you get up to a heart rate of, the examples I showed were heart rate of 300, there's no question. So that's an easy one. Sometimes even with really premature babies, Dr. Rail can chime in, but I've seen sinus tachycardia up to 260 and 270 in a really sick baby who's very premature and usually septic and terrible respiratory distress and stuff like that. And then you almost need to get your P-wave finder out, to see if you can tell. And the thing you don't want to do, if you gave a baby who was really sick like that adenosine and they were acidotic, the adenosine might last a long time. And maybe that's not what you want to do in that situation. I've seen people not be able to tell, give adenosine. I've seen babies get amiodarone. I've seen babies get cardioverted for sinus tach. So if you're not sure, it's great to have somebody else take a look at it, and two heads are always better than one kind of thing. But look for P-waves in front of the QRS, basically.
Right. Thank you. Does anybody else have any questions you'd like to ask before we break for the day?
The other thing I was going to say is that if you're looking at this later and you want to send me an email as you're perusing it and thinking about it, I'm totally happy to answer.
Great. Thank you. Thank you so much. All right. Well, guys, I think we're done for the day. If you would, don't forget to sign on or sign the sign-in sheet so that we can go ahead and know that you were here. If you have any problems, go ahead and please contact Tisha and we'll go ahead and take care of all of that. So you guys have a great afternoon and I will see you tomorrow.